Good morning again. I'd like to introduce Cadmus with Aura Bioscience. I'm not sure if any of you guys are aware, are putting it together, but this is an exciting new treatment for ocular melanoma. So please welcome Cadmus.
Thank you. It's great to be here and share this event with you guys. So we're developing a drug for melanoma, which I'll go through with you and talk about. It's a very exciting therapy and based on a platform that we have that could potentially treat other cancers as well. So Aura is building an ophthalmology company with an initial focus on ocular oncology. I'm an ophthalmologist by training. I'm the chief medical officer at Aura, and I'm very excited about what we're doing because, as you all know, this is a very difficult tumor to treat, especially in the eye because the eye is so delicate to begin with. So you have to figure out a way to treat aggressively the tumor cells, but not aggressively treat the rest of the eye. So it's a tricky one. So what is choroidal melanoma? It's probably a little bit of a primer for people, and it might have already been covered, but basically it's the most common primary intraocular tumor in adults. There's there are cells in the body called melanocytes, which are the pigmented cells. They're on your skin, they're in your eye, they're in different places in your body. And those are the cells that start to grow and they make the melanoma. So that's where the term melanoma comes from those melanocytes. There's about 11,000 patients per year worldwide diagnosed with the lesions that in the range that we want to treat and higher. And we'll talk about that. And it's diagnosed and treated by ocular oncologists. These are colleagues of mine that are typically ophthalmologists, many of them retina specialists that go on to do more training in ocular oncology specifically. And I know many of you have seen some of these people. And we talked last night, I know a couple of them very well. So similar to a melanoma in the skin, which I think conceptually it's easier. When you have a mole on your skin, it can transdifferentiate. So you go to the dermatologist and they look at you and follow you over time to make sure that mole isn't changing, especially if it, let's say, is high risk, like it looks different in color or size or shape or something. Same thing in your eye. You have moles in your eye. They're called nevi. We always have to give things a fancy name. So we call them a choroidal nevus, and then that can differentiate just like a mole on your skin. So if you think about it, it's very similar. And so the thing for us, and our big mantra is, by identifying and treating these lesions early, you can save vision and also save lives. And that's what we're going to talk about. So again, when you think about choroidal melanoma, most of the work that's being done is in metastatic disease with chemotherapy. But we're actually working literally in the eye where it starts. So the goal for us is to try and treat these lesions early and try and catch them at the very early stage. We know we won't get rid of every metastasis, but we think that if we treat early, we can prevent many of them from happening. And so that will help save lives. So, again, we want to treat as early as possible before the disease spreads. And so that's what we'll talk about. So if we think about choroidal melanoma and the natural development, there's an opportunity for us to help shift the paradigm in treatment and to try to get these treated earlier. And so if you think about, again, here's our choroidal nevus, our mole. It turns into an indeterminate lesion. It has some characteristics that don't look right. And then it becomes a small melanoma, medium, large, and really anywhere along here is the risk of metastasis, right? We know these start to metastasize early, and so even in this range, you have a low risk, but a risk of metastasis. And then as it goes along, the risk gets higher and higher. As the lesions get larger, and also, of course, when they're larger, they've been there longer, there's a higher risk of metastasis. So the earlier we can try to identify these lesions and treat them in the indeterminate small range, the better. So, how do we do that? So first of all, obviously, you have to diagnose the tumor and see it on exam, either from symptoms that you go in with, or from a routine exam where the doctor just sees it in your eye and refers you. So how do you determine these indeterminate lesions and small melanomas? They're judged by risk factors, and many of you may know this: tumor height, orange pigment, subretinal fluid under the retina where the lesion is, and also by observing growth. So the goal is to try to identify these lesions with risk factors or identify growth as early as possible, right? And the motivation for that right now with plaque brachytherapy, with proton beam therapy being the main options, those are not good options. They have a lot of problems. We'll talk about that in a minute. But our goal is basically to develop a non-invasive therapy without significant side effects that can be used very early in the treatment. So the decision isn't as hard to make to have a treatment. We think that this will shift the disease awareness and early diagnosis back to the earlier treatment, and that people will seek treatment early. And once our drug is approved, hopefully, we will be able to have disease awareness campaigns and shift that treatment as early as possible. And our target is this early, indeterminate lesion to small melanoma. If you follow a lesion for 2 years and you see growth, it was a melanoma when you started. You just didn't know. It had a few melanoma cells there. It had to have because they grow slowly. So the goal is to try to get to that high-risk indeterminate lesion and small melanoma group, reduce the risk of those metastatic patients, of people going to a metastatic disease. So the goal, again, is a safe, effective treatment can potentially shift the treatment paradigm earlier and reduce the spread. So radiation treatments are really the only effective treatments today. Some people do laser treatments, but really radiation is the real effective treatment, either plaque brachytherapy or proton beam. And the reality is these got a lot of complications and a lot of implications of the treatment. So it's a hard decision to have that treatment. And so some people actually are observed with these very small indeterminate lesions, many of which are cancer already, but they're just still in the high risk category. And then transitioning into the small melanoma, once you see growth or once the high risk gets high enough, the doctor will say, well, I think we need to intervene and make sure we're treating this. And I know there's side effects, surgeries, vision loss, and all these things that you all experience. And then it also is very burdensome on the ocular oncologist because they have to coordinate with radiation people. They have to go to the OR to do the placement of the plaques or the placement of the little clips for the proton beam. There's a whole bunch of things that have to happen. So if there was a therapy that could be done in the office that was a little bit simpler, that would be a real benefit. And it could shift that decision to treat earlier. So deciding when to treat is extremely difficult because of all these complications and all these things. So let me introduce you to our technology first and then to the specific drug. So what we've developed with the help of Dr. John Schiller at the NIH is what's called a viral-like particle. This is a very exciting technology. Dr. Schiller is an expert in HPV, human papillomavirus. This is the one that causes warts on your skin and other places. And he discovered the Gardasil vaccine that is now pretty widely used. And he also discovered that in these tumors, and not just melanomas, but in breast cancer, lung cancer, colon cancer, there's a high preponderance of human papillomavirus. And why was that? What's the reason for that? The reason for that is the capsid of this virus actually has a binding to a receptor that is only present with malignant cancer cells. And so the virus actually binds in these tumors, and then it's present there. It's not necessarily causative in all the cases, but it's coexisting. And so what John did was figure out how to make these proteins of the viral capsid synthetically in the lab. So this is not a live virus we use. It's actually synthetically made in the lab. And then it self-assembles back into a particle like the one you see here. So it almost looks like a virus with a three-dimensional spherical shape like a capsid, but it's actually synthetically made. So that's one of the things we did that reduces the risk of putting a live virus in your eye. And then the particle binds to the modified receptors on the tumor cells. And these modified receptors are present on many cancer cells. We have binding studies in all kinds of different cancers across multiple different types of cell lines in those cancers. So whether it's breast or colon or lung or melanoma, across 5 or 6 different melanoma cell lines as well. So the takeaway for this is really a platform technology to treat solid tumors. All these epithelial tumors like breast cancer and colon cancer have this receptor and potentially can be targeted with the particle. But the particle is just a vehicle that delivers something to the tumor. So what you have to do then is figure out, okay, what are we going to do with the particle to get a drug to the tumor or get something to the tumor that will kill the tumor cells? So that's where our drug comes in. What we've done is we've bound about 200 molecules, 200 to 300 molecules. You see these little red dots on the particle now. Those each represent a molecule of a light-sensitive dye. And that dye, if you know about wet macular degeneration, and people used to get treated with laser for that because they could give this Visudyne dye and then laser, and it would kill the little mini blood vessels. We have a similar dye here that we bind to the particle. And we call it a bioconjugate because it's a biological particle thing plus the conjugated dye. And so what happens is when you light activate the dye, it creates reactive oxygen species that are damaging to the cell membranes of the cells. So whatever cells it binds to, it delivers reactive oxygen species, damages the cell membranes, and causes acute death of those cells. And by doing that, it basically will kill the malignant cells. It does not bind to the benign cells or to the retina or to the lens or the other structures in the eye. So it very selectively binds to the tumor and kills the tumor. It doesn't care about what mutation you have. It doesn't care about what type of cell line it is. It's a physical killing when the particle binds and the reaction to oxygen species are made to kill that cell. So that's one of the tricks. You know, when you think about chemotherapy, usually drugs treat one pathway or this way, and it might treat 20% of people or this. The problem is you have to give something that's as good as plaque, but doesn't have the side effects. And so with this physical killing, we have the hope of delivering something that's as good as plaque without radioactivity. Okay? Are people following along? This is pretty complicated stuff, really. So the other exciting thing is that because of this acute cell death, things are released, and I'll show you a slide with a bunch of graphs on it later, that actually the immune system reacts to. And so we actually may be able to create an immune response to the tumor and prime your immune system to fight the tumor as well. And we have some preclinical data for that. We don't have clinical data yet, but we're working on that as well. So very exciting. So I think the takeaway, the VLP platform can be used to create many potential treatments. The one we're going to talk about is with this dye conjugated. But you can imagine we can conjugate a toxin to it and deliver a toxin to the tumor. We can put a gene inside the little particle and deliver a gene. So we could do gene therapy targeted just to the tumor, not to the rest of the body. So the platform has a lot of value, but we're going to move over into choroidal melanoma specifically. So how does this work? So similar to macular degeneration now, people get these intravitreal injections. We do an intravitreal injection of the viral particle, the viral-like particle bioconjugate. We call it AU011. And it distributes throughout the eye over 6 to 8 hours. And it binds to the tumor, but it doesn't bind to other structures. It washes away from other structures. So the tumor acts like a sink. Every one that comes by, it picks it up, and then the other ones are just flying around and they go away. So after about 8 hours, we have the ability to bind to the tumor cell, and that's shown here. This is the little modified receptor. It's got a fancy name, heparin sulfate proteoglycan. That's the modification that's there. And it binds to several, because the particle is fairly large, it binds to several different receptors. We call this multivalent, meaning more than one binding. And it allows great apposition of the particle and the wall of the tumor. So that allows, when we go to the next step of delivering the light, that allows the reactive oxygen species that we create to be right there where the membrane is and damage the cell membrane. So if you can imagine hundreds of these particles bound to a tumor cell all getting irradiated and blowing up the tumor, blowing up the cell. That's what we're talking about. So anyway, I think that's a pretty good explanation. Everybody following? Okay, so I think it's the physical killing and the focusing of the particle binding only to the tumor and the laser focusing over the tumor to activate the particle and the dye. It's sort of a double targeting so that the treatment is very selective to where the tumor is. So this is a novel, non-radioactive treatment that we're developing. It's still in clinical development for choroidal melanoma. So very exciting. So just preclinically, we have very strong data. We have animal models where we've done the exact same thing. We took human melanoma cells, put them in the eye, and in the same space, did the intravitreal injection and the laser, and we show great tumor cell necrosis of the tumor. So it's very exciting animal data, and this was strong enough that the FDA gave us their fast track designation, and we have orphan status. These are the kind of cool things to get so that you can try to move quicker and talk to the FDA a lot. But we got that on the preclinical data that showed the necrosis of the cells. And you can basically see this is dark, this is really a slide from pathology, but the dark is live cells, this is all dead cells. So the preclinical work helped establish the effectiveness of the drug. So the other thing that's really exciting, and this is actually fairly new data for us, is we can look at the levels of these immunogenic cytokines and things that come out of the cell that the immune system is attracted to. And that's what these graphs are. Don't worry too much about what they are, but they're showing levels of those cytokines after the treatment. And the takeaway message is that, both because of the viral-like particle and because of all of these different antigens that come out of the cells, the immune system is attracted and starts to work on the tumor. And the goal is, and what we have to prove is, that when it does that, maybe it's taking it away. And maybe it could treat distant metastases, maybe not. But that's our hope, is that we can kind of prime the immune system. So we know that it appears to induce an immune response to tumors in animal models, and it may do that in people too. So even more exciting, though, is we are in the clinic. We have a phase 1b/2 study going. That's, I'll show you a little bit of what we've done and the work we've done. We're very soon going to be talking with the FDA about future plans, and things are moving along in the clinic very well, so it's exciting. So this phase 1b/2 study that we have, there's a couple key things. First, the objectives were to demonstrate safety, but we had good results. We dose escalated higher and higher in our dose to a level is the maximum dose we think we can give, and it went really well. So we expanded the study, and that's going well, and we're going to expand it again, and I'll show you that in a minute. So now we've really added efficacy, even though it's a secondary objective. It's a very strong objective. And we have an agreed upon clinical diagnosis with the FDA. So there's a lot of talk about biopsies with choroidal melanoma. Most of the time they're done at the time of plaque surgery because it's just convenient to do it that way. And if there is any cells that come out, they get killed by the plaque. So they're not diagnostic, they're prognostic, right? They tell you class 1A, class 1B, class 2, different things like Dr. Harper and his lab and all that, and you see Castle here. They're working very hard to make those prognostic indications. But it's not as much about the diagnosis. The diagnosis is really a clinical diagnosis made on exam with the ultrasound machine. I know you guys will probably have 100 of these along the way. Ultrasound machine, photos that get taken to show the size of the tumor, and they're watched to see if they're growing. So the clinical diagnosis that we have that was agreed with the FDA is very exciting because it says every person that's randomized in the study with this set of criteria is considered clinically to have a melanoma. And that's very important when you do your research because you want to know what your treatment response is. If you say only half the people have melanoma or 40%, it's hard to know. Well, then how many of those really got treated? So you want to have that very clear, and we have that, and that's very important. You can see at the bottom the study out to 24 months, all the key time points where we get our data, and we watch these patients for 2 years, pretty intensively, and they come in sometimes in between as needed. And then after 2 years, they'll be going into a long-term follow-up study. That will actually start in March because our first patients will reach 2 years in March. So we're excited to start that long-term follow-up study. And the goal will be to follow patients longer and look at the risk of metastasis and mortality as well as how they do with their tumor, their vision, and how the tumors are growing or not growing. So 5-year follow-up total. So this is the design that we ran. We started with a 20 microgram dose. It's a small, fairly small dose injected in the eye, and the FDA made us start very low to show the safety and let it build up. So then we went to 40 micrograms and 80 micrograms. And then we started adding more treatments at weekly intervals and more lasers. So we can actually do more than one laser because the dye's photostable. So you can put the injection in at 6 to 8 hours, do a laser, and then wait 20, 30 minutes and do another laser and deliver even more oxygen to, the reactive oxygen to the cell membrane to kill more cells. So we went all the way up to our maximum dose, which is the 80 microgram dose with 2 lasers in the afternoon, and then it's given 3 times on day 1, day 8, and day 15. So the first day, a week later, and 2 weeks later. And that went very well. We had no severe AEs or side effects. We had no serious adverse events, if you know this is like an FDA criteria. No what we call dose-limiting toxicities in any subjects. So only mild and moderate side effects. And those mild and moderate side effects were what we were expecting, which was inflammation in the eye. When you put a protein in the eye, you get some inflammation. The good news is we're able to manage that inflammation with steroids. And it might last 2 months, but you can take steroids either orally or get a periocular steroid injection, or even sometimes just treat it topically, and it goes away. And then once the inflammation goes away, the eye's back to where it was before treatment. So it's quite impressive. We're in this first expansion cohort. We have 12 subjects in this. We're now, we have 8 of the 12 enrolled, and we hope to finish this by the end of the year and start the next expansion next year, where this will give us a lot of efficacy data as well as safety data for future studies. So very exciting results so far. And the enrollment has gone very well. It's a rare disease, as you all know. And so finding patients, it's kind of an interesting contrast. It's a rare disease, but the treatment centers are very specialized, so people go to very specific places, so they're concentrated. You all know, you've probably made many of those trips. So what do we look at in the study? I thought this would be interesting. I'm not really going to show you the result data because it's an ongoing study, but I can tell you what we're looking at and how we're assessing. So you all, I know, have probably gotten ultrasounds done on your eye. It's the mainstay of following these tumors and looking at the thickness. So your doctor may say, oh, it looks stable, everything's good, we'll see you in 6 months or we'll see you in a year. And what they're looking at is an image that looks just like this. And here's the tumor. And you can see it looks a little darker in the middle than around the edge, and that's kind of what you see with this type of tumor. And then you see after only 8 weeks, the tumor is much thinner than it was at the beginning. And what we do in our study is we take videos and we take multiple still images. They get sent to a central reading center. They get read by 3 ultrasound experts independently, and the results are averaged together. And we know what our variability is. It's very, very low on the readings. So the readings are accurate. And so we feel very confident and very comfortable, and I think the FDA is too, with what we're doing with the tumor thickness. We also look at the vision, and you guys have probably read more vision charts than you want to even think about. But that's also very, very important, because one of the main ways to show you don't have radioactive damage is to not lose vision. And so, when we have the inflammation that we cause early, there may be a slight drop in vision, but that returns, and once the inflammation's gone, the eye is back to its normal state. So, we have very good results for the safety and efficacy so far, and we're planning on doing these expansions and trying to get them done as quickly as we can to get to the pivotal studies, which I'll show you here. So this is where we are right now. This is our current study. That's that expansion I talked about. These were the multiple subjects, and these were the single subjects. We're right here, and we're planning on going and meeting with the FDA very soon to talk to them about our future plans, and then we're going to do that second expansion in 16 more patients. This is where we see 6 months and 12 months where we're looking at our data, and then we're planning on starting phase 3 very early or very late in 19 or very early in 20 is our goal. 5 minutes. Okay, thank you. So I told you this is actually a platform, and we can apply it to other things. We can actually apply the same drug, the same bioconjugate with the dye. It's several different indications. And then we can take the particle and do different things to it to treat other cancers later. But right now, our goal is to treat choroidal metastases. So someone who has breast cancer or colon cancer who gets a metastasis in their eye that's affecting their vision, we can treat that. And it would be almost identical treatment to the choroidal melanoma study. So we think that that indication is a natural extension. It would be fairly easy to get through the FDA. So that's our next ocular. And then cancers of the ocular surface. I was speaking with someone last night who was talking about having a melanoma of the conjunctiva, the skin of the eye. And we could topically put the drop on the drug and laser the surface. Why is that important? Because those types of cancers sometimes have these little micro-invasive pockets. And so they could be excised and recur. But if we give our drug, it penetrates into the sclera and you light activate it, in theory, will kill all the malignant cells. So the ocular surface is an exciting area, and it's interesting because several of our investigators were basically like, why aren't we using this on the ocular surface? We have these ocular surface tumors. So we're like, we'll get there. We got to go slow. It's a long process, but we'll get there. So then we can use the same drug, the same bioconjugate, with a slightly saltier formulation and use it in the bladder for non-invasive bladder tumors, which is a large percent of bladder tumors. And do a catheterization, put the drug in, and then come back and laser later, just like in the eye, but it's just a different cavity. So that's our first non-eye indication. And then some very exciting things in terms of tumor gene therapy, like I said, putting a small gene in the particle and having it be delivered specifically to the tumor. And then immuno-oncology, you guys have heard a lot about this certainly with the skin melanoma, they're having pretty good results in a fair amount of patients with survival now with immuno-oncology, these checkpoint inhibitors and some of these other drugs. So we're synergistic with that. We've shown that in animal studies that if we give our treatment and a checkpoint inhibitor, they work better together. So a lot to do there. And we're very committed to patients. So we're developing this product for the primary treatment. We're the only one in the eye trying to stop it before it spreads. We have key relationships like we're developing here with also the Ocular Research Foundation and the Melanoma Research Foundation, Cure-OM. Our program really is about transforming the journey for you guys, right? Making the treatment simpler, making the treatment not have long-term side effects. And I know we're going to have a meeting after this, talk with some of you about your experience. There will be some inflammation, and there will be a period of coming in for the 3 treatments, and even possibly doing those 3 treatments twice. So you would come in and have 3 treatments, the inflammation would go away, and get a second cycle to really make sure all the tumor cells are gone. But it would take away all the surgical complications, the droopy lid, all the things that, even with a very successful surgery that your doctor's really happy about, but you're living with every day. So I think that's part of the excitement of it as well. We have a great group of investigators. I'm sure you guys know a lot of these names up here. There's some notable names that may not be on here because their sites took so long to get started to get the research going that we couldn't put them in the study. But a lot of world-class people here, and the interest from the ocular oncology community is fantastic. Everyone wants a non-radioactive drug to treat choroidal melanoma. So, thank you.